Hello and welcome everyone. Today we'll be discussing lung ultrasound in critical care. So what are the basic signs and the machine settings? For the ultrasound machine setup, a basic ultrasound machine is suitable for any lung ultrasound. Regarding the probe selection, there is no such specific probe. You can use any of the probes that is available. Examination technique, start with the high frequency probe from the anterior fields. Then switch to a low frequency probe and go to the posterior regions. Focus and depth of the settings, adjust focus near the pleural line for better artifact visualization. And the depth setting will depend on the pathology and the region of the lung that you're trying to find out. Typically 6 to 8 centimeter depth for the anterior and lateral regions, and a deeper setting for the posterior ones to view the consolidations or effusions. The orientation of the probe can be either transverse or longitudinal, as has been shown over here. Longitudinal visualizes the upper and the lower rib and the pleura, forming the bat sign. We will show this in a better way. In the transverse, you position it between the two ribs and try to see entirely the area between the two ribs, that is the lungs of that area. So this is how it is done. You start with the longitudinal, where you will find the two ribs, which will give a dense black shadow, and then you have try to find the pleural line, which will be very thick, and then you will be having the reverberating lines that are called the A lines. So once you find some pathology or you want to see more deep, you make it transverse and then you try to see the lung in a more better way. So type of examination of the lung, there are two. The first one is a comprehensive examination, that is can be part of your daily routine assessment for ventilated patients or something like that, or you can go for a specific approach where you have something in your mind and you want to clarify for that. So we'll first discuss the comprehensive one, which includes the 12 regions, that is the 6 per site examination, 2 zones in the anterior, 2 zones in the lateral, and 2 zones, that is superior and inferior, in the posterior. Now this is used for critical ill patients to assess and monitor the aeration systematically. So once you have found that the patient has some kind of a lung pathology, you can do this serially to see deterioration or improvement. There are studies which have shown that you can actually find out whether the VAP is improving or going bad. Now next is the focused examination. This is for mostly the patient once the patient is coming into the ICU or the emergency, where you have a very specific question in mind, that is you are looking for a pneumothorax, or say you are trying to find out whether I need to drain this pleural effusion or not. Then you specifically go to that area where you are thinking there could be a pathology. Now probe and the choice and the area will depend on exactly what your question is. So as we have already shown, these are the 6 areas on each side. This is anterior 1 2, lateral 3 4, and the posterior 5 6. So 6 on 2 sides, 12 areas are the total that we have. Now obtaining and optimizing the lung ultrasound images. So finding out the pleural line is the first one most important thing. It would be somewhere around 0.5 to 1 centimeter below the rib lines, and corresponding to the parietal pleura, the visceral pleura may not be present always, but we want to see is the parietal pleura. So once you have done the pleura, identified it, next you need to do some probe movements, that is the tilting, orienting the ultrasound beam perpendicular to the pleura. Rocking, this helps to visualize the pleural line parallel to the probe's footprint. And next is rotation, where you center on the pleura to avoid the rib shadows, switching from the longitudinal to the transverse scan. Now next what you need to do, this is for again the comprehensive examination, where you need to make a scoring. So you score for the lungs aeration. So there are the 12 zones. So this is something which has already been validated in critically ill patients. We have discussed the zones, and the next would be the scoring system. In this, each scan is scored from 0 to 3 based on the aeration. So now how do we do that? Score 0 is normal aeration, where you find the A lines or less than 2 B lines. 1 is the moderate loss of aeration, where you find more than 3 well-spaced B lines or more than 50% of the subpleural area consolidated. Score 2, it is severe loss of aeration, where you find more than 50% subpleural area consolidated or coalesced B lines. Finally, there is complete loss of aeration and you actually see something like a liver, a fully consolidated tissue-like pattern. Total score, so if you score like this, the total score will range from 3 into 12, that is 36. So based on that, you can monitor the progression of your patient in the ICU. So as we have already seen, 0 is good A lines with only 2 B lines. 1 would be when you find a lot of B lines and less than 50% consolidation. 2 would be a lot of B lines, that is more than 5, or a lot of coalescence of the B line. You actually can't differentiate each line. Or you find more than 50% subpleural consolidation. And finally, something like this where you almost see it as if it's the liver. So there are some specific questions that we need to ask when we are doing a focused examinations. So this is comprehensive examination was for my daily rounds in critically ill, probably ventilator patients or patients having any lung pathology, where I want to check the progression. In this, I have a specific question in mind. The patient has come into the ICU, or patient has developed a new onset problem, or patient has just entered the emergency. One of the most common questions that we ask is whether my patient has a pneumothorax. So for that, in the ED or the ICU is to diagnose, localize and monitor this pneumothorax. It is preferred over the chest X-ray and sometimes CT, especially in unstable patient, because mind you, when the patient is unstable, getting a CT done is almost impossible. Regarding the chest X-ray, again, it's something which needs a technician and you need the machine, which is not actually always present inside the emergency, so it will take its own time based on your logistics. So the diagnostic signs are the real images or B lines, that is presence rules out a pneumothorax, which means that if I find B lines, that means there is definitely some lungs below the rib. Now it is 100% negative predictive value, which means that if I find this in all my regions, then extremely unlikely that I'm going to have a pneumothorax. Lung sliding absence suggests that there is a pneumothorax, where you cannot find that the lung is sliding over the pleura. M mode seashore sign indicates lung sliding. Lung pulse presence rules out a pneumothorax, almost 100%, again not negative predictive value. Static A lines, the absence of lung sliding makes a suspicion of pneumothorax. And in M mode, if there is a pneumothorax, what we will find is the stratosphere sign, not a seashore sign, because once the lung comes or the air comes, you find that sand type of pattern. Now lung point, here you actually see the point where the air is there and a normal lung is there. Very rare, but if you find it, it is very specific. Now the extension, you can do it at the various zones as we have told, and you can localize this lung point. Median to axillary range, less than 15% of the lung collapse, you can go for conservative management. Lateral to mid axillary line, greater collapse indicates the need for drainage. So this is what you do if you have this question for pneumothorax. Scan the anterior zone for the B lines. Okay, B lines are visible, then yes, then pneumothorax is ruled out. If you cannot really find any B lines, then you see if there is any lung sliding. Yes, then go for the seashore sign, put the M mode. If you find this straight barcodes and then dotted things like this means that there is air over here, that is the lung tissue, which rules out a pneumothorax. Next, if you still don't find it, then you look for the lung pulse. If it is present, then again it rules out a pneumothorax. Then you try to find the lung point. If you still find a lung point, then you do a M mode and you will find a barcode sign, no more seashore, and the pneumothorax is ruled in. Now scan to the lateral zone in the B line. So you from anterior, you go to lateral. The next question would be, does my patient have a pleural effusion? And if yes, how much is there? The pleural effusion detection is pretty easy. In the B mode, you will find a hypo or anechoic space between the pleuras. There is sinusoid sign where you can see the lung is actually floating in low viscous fluid. This is M mode. Sensitivity and specificity, it detects minimal effusions as small as 5 ml with 100% sensitivity, more sensitive and specific than chest X-ray. So this is always the method of choice if you are actually searching a pulmonary effusion. So quantification, comparable accuracy is there with the CT scan. So there are various formulas over here. The first one is the Geki formula, where you estimate the ml by x into LDD. The x is the craniocaudal extension of the effusion and LDD is the lung base to mid diaphragm distance. And you multiply it by 70 and you get a estimate. The next is the formula, that is Ballick's formula, where your estimated volume is 20 into x, where x is the distance between the pulmonary surface and the chest wall. Next you have the Eidenberg formula, where the estimated volume is 14.6 into x minus 837. So various formulas are there, you can use it, but then that specific calculation is not there. You can use the most simplest ones. Now it identifies pleural effusion, definitely estimates the volume and differentiates effusion types. Now it determines the indication of the chest drain insertion, placement and monitoring. The next important thing that we get in our emergencies and ICUs is patient who is hypoxemic, where I don't have much of an history and I need something to image, and chest X-ray is going to take its time, so I need something to work for. So in this, you look at the pattern for the aeration and the density. First you look for the A pattern, if there is a normal aeration present or not. B pattern, which will indicate that there is some fluid, and it can range from well-spaced B lines to merge with almost what we can call as the white lung. Consolidation pattern, where you can find a very thick tissue-like structure like a liver. Now evaluation approach. First you start with the anterior fields, begin with the anterior fields, extend to the lateral and then go to the posterior. A pattern, normal aeration, no pneumothorax, confirmed by the lung point, or if there is pneumothorax, we have already discussed. Lung pulse indicates regional ventilation, suggesting conditions like COPD, asthma, hyperinflation. Normal lung sliding with subpleural consolidation suggests pulmonary embolism, follow up with a cardiac and vascular ultrasound and right ventricular issues, and then try to see for deep vein thrombosis. The B pattern, focal, subpleural, monolateral, suspect embolism or pneumonia. Diffuse B lines, probably cardiogenic origin, with reduced sliding, thickened pleura, without effusion, then it is probably an interstitial pneumonia with ARDS. Now, diagnostic accuracy of all this, the sensitivity and specificity based on various meta-analysis around 92% for sensitivity and 98% specific. So actually when you do find a lesion, then it is quite specific. But then if you don't, that doesn't mean that that particular disorder is not there. Pulmonary embolism, combination of the A pattern with DVT and subpleural consolidation, again 90% sensitive, 86 specific. Integration into the clinical practice is important. It is recommended to use this to evaluate pulmonary edema during heart failure and assessing fibrosis or sarcoidosis. Automation with modern software for LUS interpretation is being explored, but currently it is not the gold standard. So this is something you can use. So first scan the anterior areas. If you find A lines, you check whether the lung sliding is present or not. If it is not present, and then check for the lung point, and probably you're going to something what is called as pneumothorax. Next, if you find normal lungs, then you look if there is any subpleural consolidation. If there is, then you look for the echo and the vascular and try to see if there is a pulmonary embolism. If you don't find a pneumothorax and you still find the lung pulse, then there is probable impaired regional ventilation, which could be because of hyperventilation, selective intubation, atelectasis, COPD or asthma. So this is about A lines. Now once you do not have those A lines, that means there is some kind of a fluid present in the alveoli. So it can be focal, diffuse with thin regular pleura, or diffuse with thick irregular pleura. If it is focal, then check if there is consolidation. If it is monolateral, then it's pneumonia. If it diffuse with thin regular pleura, then check if there is pleural effusion. Then probably we are going to something which is called as cardiogenic edema. And if it is thick pleura with consolidations, bilateral, then probably we are going into ARDS. But keep in mind, there are specificity and sensitivity issues. It is not 100% or the gold standard for diagnosing all this. It gives you an idea before you can start and do more confirmatory tests to confirm these findings. The next question that we ask is whether the patient has a ventilator associated pneumonia or not. This is important because I need to start my therapy early. Do I wait for the chest x-ray or I do an ultrasound and find? It has been shown that it does help, because once you have a suspicion based on the clinical criteria that we have, you collect your microbiological samples and use the lung ultrasound as the diagnostic modality. The consolidated lobe visualization is highly specific for pneumonia diagnosis. Dynamic air bronchograms indicate VAP but rules out the obstructive atelectasis. Static bronchogram with absent is a non-patent airway, indicating the need for this obstructive fibrobronchoscopy. Now, diagnostic accuracy is 91% sensitive, but if you find it, it is very specific, almost 100% better performance than chest X-ray and CPIS. Color Doppler in lung ultrasound evaluates the vascularization in the consolidated lung regions. Detection of good perfusion in non-aerated indicates there is a lot of shunt present, contributing to the hypoxemia. So in this, if you find consolidations in mechanically ventilated patients, then look for static air bronchogram or dynamic. If there is dynamic, then think of VAP and go for a bronchoalveolar lavage. If it is static air bronchogram, that means there is some kind of an obstruction. So do a disobstruction, check for the underlying mechanism why there was an obstruction, and reassess with the fiber optic bronchoscope. The next is whether my patient needs a PEEP or proning. This is for ARDS patients, obviously. So this is for personalizing. Again, mind you, what we are discussing over here is not something which has been proven in literature. This is something which we are thinking will help in the management of patients by use of lung ultrasound. Here you do your lung ultrasound scores, check whether it is focal or diffuse, anterior, most discriminative for a focal and non-focal morphology. Prone responders are those who have a focal distribution with severe posterior aeration loss and spared anterior areas. So these are the patients who are going to be the best responder to proning. And PEEP responders are someone who has a diffuse distribution with compromised aeration in almost all the fields, including the anterior ones. So PEEP versus proning. In prone positioning, generally beneficial for focal pathologies, significant improvements in oxygenation. PEEP for diffuse pathologies, and as we have discussed this, look for the distribution of the lung scores are focal or non-focal. If it is focal, then prone. If it is non-focal, then perform a PEEP trial. Next question is, when I'm trying to extubate the patient, what are the chances that my patient can have extubation failure? Extubation is a very important thing, and predicting extubation failure is very, very important. So global lung ultrasound score more than 17 or anterolateral lung ultrasound more than 5 indicates a high risk of post-extubation respiratory support requirement. Weaning failure is identified changes in the lung aeration, which includes pulmonary edema, unresolved lung issues, inadequate respiratory muscle strength. Thank you for your patience.